Good afternoon. This is EMS Medicine Live. This is our November 2017 edition. If you notice, I've cut out the intro slides trying to streamline our presentation, so I'll just keep it a little shorter than I've done in the past. Of course, we're using Zoom. This session is being recorded. We will post this afterwards on YouTube, Facebook, our webpage, and anywhere else we could think of to put it. I've kept everyone on mute this time. As you joined, we just muted your session to kind of keep things a little quieter in the background for the presenter. If you need to unmute yourself, go ahead. But generally, if you have any questions, try to wait to the end to unmute yourself to ask a question. If you need to text me a message, you can instant message me on EMS Medicine Live using the Zoom software, and we can decide if we need to break in and ask the question or if we just wait to the end. But at the end, we'll make time for questions if anyone has one. This month, we're lucky to have Jeff Lubin from Penn State Health present for us. He is a graduate of Robert Wood Johnson in Jersey. He is one of the Pittsburgh Mafia graduates, having done his EMS fellowship back in, I think, 2002 to 2004. So when I started at Pitt, I just missed him. He went off to Case Western for several years, but now is working at Penn State as their Division of EMS Director and the Program Director of their EMS Fellowship. So with that, I'll let Jeff talk about pre-hospital hemorrhage control.
Well, good afternoon, everybody. Hopefully the weather where you're at is nicer than our cloudy, rainy weather here in Hershey. The nice thing is that apparently they're roasting peanuts down the street because our parking lot smell of peanuts. At any rate, we're going to talk about bleeding control in the pre-hospital environment. Any of you who have seen me lecture in the past, I usually come up with some kind of gizmo, gadget, gimmick, something to make my presentations interactive, and I'm going to at least try again today to make that happen. We'll see if it works or not. So what I'm asking you to do, if my computer were to go, is to join me for the session. So how are you going to join me? If you can, there's a couple ways to do it. There is a Poll Everywhere app that you can put on your phone or your iPad. It's free. And come and join into my session, which is Jeff Lubin 632. However, it might be easier if you just log into the website, because I know you're all on computers somewhere in order to listen to this. So the website to go to is pollev.com/Jeff Lubin 632. This is where you'll respond to things. I'll put this up again in a couple minutes for any stragglers, or if you are having trouble or it's taking time to download or whatever. And if you are living in the dark ages and have a flip phone and still want to join us and don't have access to all these other things, you can actually send a text message to 37607. You type in Jeff Lubin 632. That'll join you into the session, and then you can text your messages. I should warn you that if you have a flip phone, you probably pay by the message, and standard text messaging rates will apply, so the legalese that you would expect. So anyway, I do mention a number of products during this presentation. I have no financial interest, unfortunately, in any of the products that I mentioned in the talk, which is a pity because some of them are really pretty cool, but I have no financial interest. So let's start. Bleeding kills people. I think we know that. If you look at CDC data, this goes up through 2014, you can see that in age groups from 1 to 44, unintentional injury continues to be the leading cause of death in this age group. And if you pull out devastating brain injury, hemorrhage is the #1 cause within this category. So I don't think that's any big surprise to people. And if we go back to the basics, even when you were a Boy Scout or a Girl Scout, you learn the basics of hemorrhage control. And we talk a lot about direct pressure, either by a gloved hand or sterile dressing, or if you don't have a gloved hand or sterile dressing available, take the person's own hand and stick it on. That's what I teach my kids. If that doesn't work, you elevate the extremity, try to get it above the victim's heart and continue that pressure. And then maybe you were taught pressure points at some point, and different areas that you can press on in order to reduce the bleeding. So that's no big deal. That's stuff that any elementary school kid could be taught. It's the first line, and it works pretty well most of the time. But what happens if it's not still controlled? And that's what I'm going to focus the talk about. What happens when you use all those conventional methods and the person's still bleeding? Okay, here's that part where I said I would give you those numbers again. If you have completed downloading the app because you wanted to put it on your phone, the sessions, Jeff Lubin 632. Here's a website again. And here's the text number again. Again, I don't know, frankly, if this Poll Everywhere app is going to work. Thought it would be kind of cool since we're all over the place to see if it would happen. So my goal in the next 45-ish minutes is to try to add some things to your bag of tricks. Except if you're like me, your bag of tricks doesn't quite look like this. It looks more like this. And it's probably a little overstuffed already. So we want to think about what works and what doesn't work, what data is out there, what evidence is out there, and what makes sense for us and our providers to carry. And that could be for the patient like this, where you have one patient where you can focus on and you may have more personnel than you do patients. Or it could be a scene like this, where you have more patients than you do providers, in which case your tactics might be a little bit different. And which of these will be filling your bucket? Which ones should you put in your bucket, and which of these should you probably put to the side for now? So I figured I'd do this by cases. So case one is a 15-year-old male. He sustained a laceration to his right arm when he struck a glass window. Frankly, honestly, this is a real case. The bleeding is not currently under control despite all of the basic maneuvers. So tourniquets have come into practice and kind of had a renewed interest in these, and that would probably be the answer. A lot of people would say, well, I can't control bleeding with conventional maneuvers. It's in an extremity. Let's apply a tourniquet, and you can get nice bleeding control. So here's the first chance for us to try to do this. Does your EMS system carry commercial tourniquets on board? I'll wait for a minute since I can't. Oh, something's working because something came up. I got a yes from somebody. Maybe a yes from multiple people, I don't know. I'll give it another moment. It looks like we got a big resounding yes, which is good. But it wasn't that long ago when tourniquets were really not clear. They were controversial. Even as recently as 2003, this article from the Journal of Trauma described the tourniquet as an instrument of the devil that sometimes saves a life. They said in that same article that the balance of risk is unclear, whether the risk was outweighed by the benefit. They said that the efficacy was controversial, and I'll quote the article. It says it was unduly influenced by folklore and dramatic Hollywood images. So if you think back to the times that tourniquets have been placed in some kind of drama. They concluded by saying that most extremity hemorrhage, including that from traumatic amputation, can be controlled with direct pressure and elevation. So at least as recently as 2003, they really weren't convinced. They said it's unlikely that there's any exclusively clinical situations in which a tourniquet must be applied to arrest hemorrhage. So we've had a real change in thought since then. And it was only a couple years later that this article came out. This is from the Journal of the American College of Surgeons in 2006. This was a study done in Bethesda, Maryland. And they started rethinking the idea of tourniquets and said, well, we're not sure if they work or not, but providers should probably be trained in using them so that they at least understand the risks and the potential benefits of these pieces of equipment. And then once we started to get into more wartime stuff with Afghanistan and Iraq, they really started to gain some data. So this study is from the Journal of Emergency Medicine from 2011. And this was data taken from a military hospital that supported combat participants as well as security workers in Iraq. The total population was nearly 500 people. They applied over 800 tourniquets. And overall, the people who survived was 87%. Survival was associated with pre-hospital application, so that makes it particularly appropriate for us to talk about. So 89% of the folks who had their tourniquet applied in the pre-hospital environment survived versus 78% if the tourniquet was applied in the hospital. And they also saw a survival benefit, in fact, a very huge survival benefit, if the tourniquet was applied before the onset of shock. So that was 96% before versus 4% after. So it makes sense that if we're going to use a tourniquet that we should use it early. It makes sense that the EMS medicine community should be talking about these and their applicability in our environment. There's lots of pictures like this out there about improvised tourniquets, what you can do with pieces of cloth and sticks, and potentially they might be better than nothing. But commercial tourniquets are probably what our units should be carrying if you're going to carry the tourniquets. And there's several different varieties out there. The combat application tourniquet's one of the most popular ones. In fact, it's what my units are carrying here. It's considered one of the fastest tourniquets to employ, and you can do it by two different ways. You can do it two-handed or single-handed. So if you needed to put it on your own arm, you're able to do that. The difference is just where you route the strap. Once you get the slack out, you turn the little windlass, the rod-shaped handle, and then put it into the Velcro strap to keep it in place. Another commonly used tourniquet is the Special Operations Forces Tactical Tourniquet, the soft T. Another commonly used one also has a windlass design similar to the combat application tourniquet. Comes in two models. The original model had a 1-inch strap. There's a wide model that has a 1.5-inch strap. One of the things that's different, I don't know if my cursor will come up, I'm assuming it will, is this thumb screw over here, which helps tighten things, which is sort of a benefit as well as a distractor from it. It doesn't work well in certain conditions, but it's been one of the areas that gets criticized. It's very similar to apply one of these tourniquets as it is to apply the combat application tourniquet. And some people say that the soft T's better down low when you have both your hands. So some places will carry a combat application tourniquet for upper extremity hemorrhage, and then we'll carry a soft T for lower extremity hemorrhage. Less common is the SWAT tourniquet. One of the things about this is that the name of the tourniquet helps remind you what you're supposed to do with it. It's a 4-inch wide strap of rubber that gets wrapped on itself and then tucked in place. Has a wide footprint, so at least in theory, it should reduce the amount of direct tissue damage that you cause. On there, you can actually see in the picture, these little geometric shapes here, when you stretch it out to the appropriate tightness, are supposed to stretch out and become squares. That's how you're supposed to know. There's other symbols along the way that they tell you how tight. Frankly, if you're using it, you're probably placing it as tightly as you can. So it's a neat little gimmick, but probably not that important. It can be really hard if you're trying to apply this to yourself. You really need two hands to do it well. But people find it a versatile tool to have in their jump kit anyway, because you can use it for a whole bunch of other things too. You can hold a pressure dressing in place. You could secure a splint with it. You could chop it up and put it in a signal fire to make black smoke. So there's lots of different things that you could do with this. It's relatively light and relatively cheap. And in fact, it's probably the cheapest of all the tourniquets on the market currently. Last, I wanted to bring up the rapid application tourniquet system. The reason I think this one's sort of unique is that it has the smallest footprint of all of them, so you can throw it into small pouches. Might be potentially useful for a tactical team because it doesn't take up a lot of space and it's pretty light. It's basically a 1/2-inch bungee cord with a metal cleat that you use as a locking device. The bungees run through there, you create a loop, and then you run the tourniquet through the loop. You have to apply multiple wraps around there, and that helps distribute the pressure. One of the criticisms of this particular tourniquet is that you can end up applying all the force along this one little 1/2-inch space, which could lead to more tissue damage. One of the other criticisms of this is that it actually takes a fair amount of range of motion in order to apply it correctly. And if you're wearing body armor in a tactical situation, it could be really hard to apply. So, out of curiosity, what are you guys carrying? Wondering if I'm only getting one person.
It might just be me, Jeff.
It might just be you. We're carrying the same thing. I'm just think it's kind of cool that this is working from a couple hundred miles away from you. So we carry the same thing at my program here. If you are going to use a tourniquet, just basic tourniquet instructions. Make sure it's directly on the skin, not over clothing. Make it 2 or 3 inches proximal to the wounds. Try to stay away from joints. One of the things that I actually recently did a protocol test with my programs, and this was an area that required some re-education, that it's not just tightening it till the bleeding has stopped. The idea is to tighten it until the distal pulse is absent, if there is a pulse for you to find. And then, of course, mark the time of application of the tourniquet. Talk more about the pulse in just a second. There's reasonably good literature that up to 2 hours with a tourniquet on is probably safe and does not result in much of an increase in nerve palsies or decreased tissue patency or further amputation. So 2 hours is the number. And that's the number that they used in this particular study from the Journal of Emergency Medicine, again, 2011. They found that nerve palsy was less than 2% and major limb shortening was less than 1%, which wasn't necessarily attributed to the tourniquets, but potentially could have been. So let's go back to our patient. Remember, he's the 15-year-old kid who stuck his arm through a wall. His vitals are getting better. His heart rate's now 110. His blood pressure is 136/97. But he starts complaining that the tourniquet really hurts. So what do? And this is another area where sometimes I find I need to re-educate the crew. Remember that the goal is to stop the arterial blood flow. In order to stop the arterial blood flow, you need to compress the tissue around the vessel, which then compresses the vessel. When you compress tissue, it hurts. So a properly applied tourniquet may end up hurting a patient if they're not otherwise in shock and not able to identify it. You should be tightening these things pretty tight, and you want to do it until the pulse is gone because it will decrease the chance of developing a compartment syndrome later. I think that makes sense from a physiology perspective. If you're not tightening it enough to compress the arteries, it may have compressed the veins, but not the arteries, which means you could potentially be pumping some blood into that distal area and not having any capacity to return it because the veins have collapsed under the pressure. So make sure that it gets tightened until there's no distal pulse. If you've placed it and you can't get it any tighter, well, try to tighten it some more. If you still can't do it, maybe you need to put 2 tourniquets side by side in order to apply the amount of force needed to create compliance. Okay, let's go on to case 2. You watch the time too. An 81-year-old woman presents with numerous injuries following a fall down a flight of stairs. GCS of 15, but she looks pale. She reports feeling dizzy. EMS finds a hemorrhaging scalp wound. So what do you do here? Well, obviously you can't apply a tourniquet. So what other options are there? Well, maybe you would apply a hemostatic dressing. So there's a number of different hemostatic dressings on the market, but they, well, sorry, I have another slide here. Let's see what Christian's doing at his program. No hemostatic dressings.
Someone else did it.
Well, wait, someone else is here. Uh-oh.
Multiple answers.
What do you know? So a lot of programs are carrying them, at least the ones that have logged into us. So 75% of the programs are carrying them. And there's basically 2 flavors of hemostatic dressings. Either the kind that will concentrate the factors or some kind of mucoadhesive agent. Kaolin falls into the first category. It initiates the intrinsic clotting pathway by activating factor 12. And then that also activates platelet-associated factor 11. So if you look at this, and hopefully your eyes don't bug out, unless you're a heme geek, you don't like this stuff, it's up here that the pathway starts the cascade to eventually create the clot that you want, way down in here. So if you think back, boy, this stuff has a sketchy history. So initially they were using zeolite, and it was causing burns and war casualties. So the first generation of quick clot was using zeolite, and what would happen is as the water from the plasma was adsorbed into the zeolite, it created an exothermic reaction and created some significant burns. So then they went on to a second generation, and this was sort of a beanbag device that they put in place. And that worked a little better because it was partially hydrated, so there wasn't as vigorous of an exothermic reaction. And then the latest edition, and this is what we have in our trauma base at Penn State Hershey, and it's what we're carrying on board the helicopters and ambulances here, is combat gauze, which is basically cling roller gauze that has the kaolin impregnated in it. Chitosan's the other main material that's out there, and what it basically is a charged particle that helps bring all of the cells and platelets to the surface to try to make them more present. Okay, if it's chitosan, that's from chitin, and isn't that from shrimp, and does it cause allergic reactions? At least according to the manufacturer, it does not cause allergic reactions, and there's been no real documented cases of that. Whichever agent you decide to use, you have to put the bandage directly onto the bleeding area because it needs to be in contact with the wound. You can place additional bandages over it if you need to, but make sure that you get that bandage all the way in so that it's contacting the bleeding site. But the real question is, do these things work? Most of the experience we have using these is military, not a big surprise. And again, Iraq and Afghanistan have given us a lot of data about this, and the results have really been mostly positive. And you can use it on these big wounds. These are IED wounds, deep wounds, extensive wounds. Again, big, large areas that would be hard to otherwise take care of. Potentially, maybe you get a tourniquet in up here, but it's a junctional area that makes it more difficult. The reported failures were typically because they couldn't get the material to the site of the bleeding. Again, it needs to be in direct contact with the area of bleeding for it to work. The other thing that they tended to blame was coagulopathy of trauma. About the same time these dressings were coming out, there was a big push on the use of recombinant factor 7, NOVO7. And ultimately, the literature doesn't seem to have panned out on the use of NOVO7 for coagulopathy of trauma. But that's why there was a focus on that. The civilian applications of these products started not too long afterwards. So this is an article from 2009. It's one of the earlier articles. In this one, they used Hemcon, which is a chitosan derivative. And they say at least 25 out of their 34 cases, direct pressure did not control the bleeding. And then 76% of those cases, within 10 minutes, the Hemcon did work. 7 cases, they were not able to stop the bleeding, but at least they report that it was user error, and presumably they didn't get the bandage in contact well enough with the bleeding site. The other side of this, though, is there are several bench studies where they looked at the different agents that are out there and compared it just against standard gauze dressings, direct pressure. And at least in this study from Academic Emergency Medicine 2011, proper wound packing and pressure was at least as good, if not a little bit better, than any of these hemostatic dressings. And here's another one, very similar, from the Journal of Emergency Medicine, also from 2011. They used a similar model, a swine model, where they caused hemorrhage near the femoral vein. And in this case, equally effective to the available agents. So I was curious what was more recent. Again, we have more war experience than we did before. And these agents have made their way out into the EMS environment. Here's a study from this year from the journal Injury. It's a study from the Netherlands. And they looked at 66 patients that standard care was not providing adequate control of bleeding. Out of them, 13 of the 66 chitosan derivative, it was a HemCon product, resulted in reduced hemorrhage and was unable to control the hemorrhage in only 7. They say that there was user error in 3 of them. So weakly supportive, I think. This is a study from 2015 looking at the Israeli Defense Forces. They applied a hemostatic dressing, and this was actually quick clot. And out of the patients that they weren't able to obtain bleeding control with standardized therapy, they were able to get successful control of the hemorrhage in just about 90% of both junctional hemorrhage and extremity hemorrhage patients. I think this summarizes, frankly, how I feel about the hemostatic dressing. So this is from an anesthesiology journal from 2015. They took a look at the data that's out there, reviewed the studies that are out there, and one of their ultimate conclusions is there's a lack of clinical trials using these agents, that most of the data that's out there are anecdotal reports or studies in the lab using something like a swine model, so that the data really isn't that strong behind them. I tend to agree with that. To put the last 2 devices into perspective, tourniquets as well as hemostatic dressings, I wanted to make sure you guys were aware of this article from 2014 from Prehospital Emergency Care. So it's an article that describes the development of an evidence-based guideline for prehospital external hemorrhage control. They did a systematic review of the literature regarding the use of tourniquets and hemostatic agents, in particular for management of life-threatening extremity and junctional hemorrhage. They used something called the GRADE methodology to look at the key clinical questions, and then had an expert panel that reviewed the results of the literature review, established the quality of the evidence, and then made recommendations for the care. And this is what they ultimately ended up coming up with. So first step is, again, Boy Scout method. Apply direct pressure and pressure to the injury. If that works, you're done. If it doesn't work, if it's an extremity injury or a place that you can place a tourniquet, then apply the tourniquet. If it's a junctional injury or a place that you're unable to apply a tourniquet, then put a topical hemostatic agent there with direct pressure. So this is the recommendation that our main societies are supporting as of 2014. I wanted to go into some of the other stuff that's out there. I think other things that are less proven, and some things that might even be a little controversial. So we'll do that for the next 15-20 minutes or so, and I'll talk about the future a little bit too. So this is a real case, a 47-year-old man who tried to take his own life with a knife and a broken glass bottle. EMS gets there and finds active hemorrhaging from a neck wound. He had 19 lacerations in total. 2 of them were considered severe by the EMS crew, and 1 slash on the upper chest had what they described as arterial hemorrhage. And this is what they used. Some of you guys may be familiar with this or have at least seen this device at trade shows. This is called an IT clamp. The concept behind this device is that it grabs the edges of the wound and then clamps it together in order to tamponade the bleeding. They say that this is information from the manufacturer. You can use it in the extremities, the axilla, the inguinal area, the scalp, and the neck. So I could see this potentially helping on the lady that fell down the stairs with the bleeding scalp wound as well. They promote a number of papers that give preclinical evidence for working. Again, the most common model that's used in hemorrhage management is the swine model. but there are several different papers out there that are at least preclinical. There are also a number of case reports similar to the case that I just presented, which came from one of these case reports out there, but these are generally isolated. And then I thought this was an interesting paper. So this paper took a look at self-care and whether or not after applying a tourniquet or an IT clamp, if they could get back to firing a firearm. And in this case, it was much more difficult for them to use their firearm if they had a tourniquet in place versus if they had this IT clamp in place. So if they're going to continue to battle, either in a war-type environment or in a tactical EMS environment, this gives at least a little bit of data to support the use of the clamp device. And how about comparison to other methods? Well, there really isn't any yet. I think it's a little bit too early to determine if this device is going to go the way of mass trousers or if it's going to be something that's going to be useful in the future. So I'll keep my eye on it. One more, and this is getting into a more interesting and hot topic type area. A 26-year-old man, a pedestrian, struck by a vehicle moving 40 miles an hour. When EMS arrived, the patient is complaining of severe abdominal pain. He has a distended abdomen, and his vital signs show evidence of significant shock. So, of course, when you see a patient like this, you think, well, what could be causing it? And this is also a standard question that you'll ask EMS crew members. Why is he hypotensive? Is it spinal shock? Where is he bleeding? And the answer is bleeding, 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 maybe some other stuff, but obviously he's bleeding. So standard EMS care would be to start 2 large bore IVs. Obviously there's some debate on how aggressively you resuscitate these patients. Do you get them up to normal vitals or do you allow them to be somewhat hypotensive? I'm not going to get into that for the purposes of this talk. What I am going to get into is things that we do and don't do anymore. We actually still have a pair of these out in our shed somewhere. I pulled them out to show the residents a couple months ago. But mass trousers have clearly gone away. We'll see if they ever cycle back because that seems to be what happens in medicine. This stuff isn't going to work on this patient. I've given you at least some idea of the evidence behind it, but it's not going to work on the guy who appears to be bleeding into his belly. What about this stuff? So definitely a hot topic right now is the use of tranexamic acid in patients who have significant trauma. And the question that EMS providers, or even I'm guessing some physicians have, what is this stuff really and what's the evidence for our systems to be using it? So I will go back to the coagulation cascade a little bit to just put it in perspective what this does. Remember that the end of the pathway is that fibrinogen goes to fibrin and that starts making your clot. And it makes its way back up through prothrombin, thrombin, and factor 10 and activated factor 10. That's the common pathway. Well, then once you have the fibrin clot, your body starts to break it back down. So if you're taking care of a patient who's in DIC or suspected DIC, one of the things you look at are fibrin degradation products. Do you have an increase in that? And it's plasmin that does that. So we take advantage of this in our stroke patients and sometimes in our STEMI patients as well, that we use TPA to help convert plasminogen into plasmin, which then helps to break down those clots. If you give someone an antifibrinolytic, that does the exact opposite. So there's several antifibrinolytics out there, and they've been used in the operating room for a long time. These aren't new agents. Aminocaproic acid and PAMBA are 2 others that are out there, but the one that has gotten the most traction recently is tranexamic acid, TXA. So the idea is, how do you balance out clotting versus bleeding? If you give someone TPA, you make them bleed more, or at least you reduce their clot burden. If you give someone an antifibrinolytic, you make them clot more, which might be what you want them to do when you have someone with a significant traumatic injury. So here's a paper that really put a spotlight on the use of TXA in trauma patients. This is the CRASH-2 trial. It was a very large trial, which included 20,000 patients. It was prospective and randomized. It went across 40 different countries. And what they found was when they gave these patients TXA, the all-cause mortality was reduced from 16% down to 14.5%. And in particular, the risk of death from bleeding was reduced from 5.7% to 4.9%. So that seems pretty good. All-cause mortality went down by 1.5% and death due to hemorrhage down by 0.8% in a large prospective randomized trial. Seems like good data. If you look at the number needed to treat, that's 1 in 67. So for every 67 patients you give TXA to, one of them will have benefit from it. And when you put that in perspective, a lot of the other stuff that we do for patients have numbers that are nowhere near there. So we give patients aspirin all the time who have a chance of MI or stroke, and that's 1 in 1,667. Even the use of magnesium in preeclampsia has less favorable numbers than this does. They've done sub-analyses, and this makes TXA even more important for an EMS medicine group, that if you give the TXA within an hour of injury, that the risk of death decreases from 7.7% to 5.3%. You still get some benefit within 3 hours, 6.1% to 4.8%. But if you give it after 3 hours, at least according to this subgroup analysis, your risk actually goes up. So you've gone up from 3.1% to 4.4%. So the idea is to give this stuff early if you're going to give it, at least according to this particular subgroup analysis. Just a summary statement of what I just said. Okay, timeout. This stuff sounds really good. Seems like we should all have it on board our ambulances and helicopters and maybe in the back of our cars to use just in case. But there's more to it. If you look at CRASH 2 critically, there's a lot of flaws with how they did it. 50% of these patients who were supposedly having critical hemorrhage didn't get any packed red cells at all, and nearly 50% of them, I'm sorry, more than 50% of them didn't have any surgical procedure done. There was wiggle room in when the patients got it. Patients received it when it was clearly indicated in the treating physician's judgment, but they didn't have any criteria around that, what that meant. So it really created more of a gray zone than you'd like. There have been some subsequent studies. So the MATTERS trial is another big trial that supports the use of TXA. They saw a decrease from 23.9% down to 17.4% for in-hospital mortality, and for patients who were on massive transfusion protocols, the mortality was actually cut almost in half. However, one of the things they did see here, because we're using antifibrinolytics, is that there was an increased rate of DVT and PE in this particular study. There are other studies out there, and there's more on the way. There are several pre-hospital studies that are underway. So I think that the early adopters probably are thinking about putting this on board or may already have it on board. I think those of us who may be a little more conservative about it are waiting to see what happens. So, are you a TXA believer? Curious what's out there?
There's no maybe.
So that's kind of interesting. The group is split, which makes sense because I think the data right now is leaning towards its benefit, but I don't think it's clearly there just yet. Interesting. Okay, let's go on. Got a couple more to go. Case 5, a 24-year-old man was the driver of a motorcycle involved in a head-on crash into a truck. Complains of abdominal and hip pain. EMS finds an unstable pelvis. His blood pressure is 84/60, his heart rate's 114. So you suspect this fella has a pelvic ring fracture. If you think back to what you know about pelvic ring fractures, one of the classification systems, the other system is the tile system, but one of them is the Young classification system, which is potentially useful in thinking about these fractures. In the Young classification system, there's 3 major fracture patterns, and it's based on how the injury is obtained. You can either have a lateral compression, which is about 50% of the time, and antero-posterior compression, which is probably what happened with this guy with a head-on collision, which happens about 25% of the time, or it can be a vertical shear type injury that's usually from a fall, about 5% of the time. The remaining is some kind of mix between all of those. So this is what happens with a lateral compression. The force comes from the side, resulting in a crush fracture of the sacrum and internal rotation of the hemipelvis. In the anterior-posterior compression, often there's a disrupted pubic symphysis, as well as the posterior parts of the pelvis, including the venous plexus that sits back in your pelvis. And then finally, in a vertical shear type injury, part of the pelvis is displaced superiorly compared to the rest of the pelvis, resulting in disrupted ligaments as well as the blood supply across those lines. So how do you manage them? Well, the typical management, ABCs and initial stabilization is what you would always do. But what about pelvic splinting? So the idea behind splinting makes a lot of sense. If you can apply some compression, you leave less space for blood to accumulate. If you leave less space, you can create a tamponade so that ruptured vessels are less likely to bleed. Moreover, if you can stabilize the pelvis, you're less likely to have further damage during transport, and incidentally should reduce pain by limiting movement of the pelvis. So we do this for other bony injuries as well. There's more than one way to splint a pelvic fracture, and I'm going to talk about all of them, at least briefly. If you're going to use a hospital draw sheet, make sure it's centered and twisted around. Once it's tightened, you've got to do something with those ends so it doesn't loosen, so it needs to be tied really well or otherwise clamped down. I would say this is probably the least good way of doing it, but probably the most available way of splinting a pelvis. Sort of looks like this. Remember that this should go across the greater trochanter. One of the advantages of using this particular system is you can use it while the patient is still inside of a car, if this happens to be a car accident. If you look at some of the EMS-related blogs and listservs out there, they'll talk about using an inverted KED in order to splint a pelvis, which you can see how the sort of wraparound feature of a KED, that would make sense. Maybe the only good use for a KED. The truth is there's pretty much no literature out there. The only thing I could find was this one study from the journal Injury, and they were applying a KED pretty much the same way that you would apply to extricate someone from a vehicle, and the leg straps ended up increasing the pubic symphysis distance rather than decreasing it. So there's really very little to no data out there, and in this study they said you needed to add this trochanteric belt, which is basically a couple-inch piece of fabric that was wrapped around the greater trochanter to keep the hips in place. That probably provided more stability than the KED did. There's those mass trousers again. If you happen to still have them collecting dust in your ambulances, you could potentially inflate the top compartment of the pants to you could potentially inflate the top part of the pants to create a splint. There are, however, several commercial devices out there. This is one of them. This is the SAM pelvic sling, which again goes across. The T-pod is a little bit of a wider device, looks a little bit more complex, but does basically the same thing. Any of the pelvic binders should be, again, applied at the level of the greater trochanters. Be careful, I've seen it happen even in our trauma bay, that some people just want to show how strong they are and apply these things as tight as possible. That's not the goal here. The goal is to get an anatomical reduction so that the patella should ultimately appear neutral. Is there any data about this? Well, the truth is there's not as much data out there as I expected when I started looking. In fact, there have really been no studies that show any mortality improvement when you use a pelvic binder. There have been no studies ever. And the truth is there aren't even really any good cohort studies. out there right now. What is there? Well, there's one observational study from 2010. They looked at 15 patients. Their endpoints were mean arterial pressure and heart rate, and those seemed to get better 2 minutes post-application. And that was an in-hospital study, not a pre-hospital study. There is one other study out there that said that there were decreased transfusion requirements and decreased hospital length of stay, again with in-hospital use of pelvic binders. And this was compared to external fixators, which take longer to put in place. At least if you think about it from a pathophysiologic sense, if this, you go back to that Young classification, if it's an AP compression injury and the symphysis has opened up and the posterior elements of the sacroiliac joint have opened up, maybe that venous plexus has torn, kind of makes biomechanical sense. There is some, again, low-level evidence that this helps. If it's a lateral compression injury, which is the most common kind of injury that we see, it really doesn't make any biomechanical sense. It may actually displace the fracture piece more. So that really doesn't make sense. And if it's a vertical shear injury, the data has really been mixed. So there's some evidence that you get some hemodynamic improvement, but there's also been data out there that some patients have clinically significant deterioration. So you may actually make the person worse. And this doesn't even include those mixed injury types that I mentioned before. So what to do with those? I think the data has yet to be determined. Last little piece I want to talk about is sort of EMS of the future. Here's your newest ambulance coming in. It's going to be a drone or somehow hover onto the scene so that you can load your patient. And what are your EMS providers going to do then when they have their traumatic patient? Well, maybe they'll use some self-expanding foam. This is being researched right now. It's mostly through the military. And the idea is that they inject it through the abdominal wall and then it expands to create a tamponade. It's just like, well, similar to what the surgeons do when they pack a belly up in the operating room. There are some studies out there. This one happened to be a dose-finding study, but there's not a lot out there just yet. Results remain to be seen. Well, what about Reboa? That's getting a lot of talk right now in the trauma circuits. Can you do a non-invasive or minimally invasive way to stop bleeding? And could this even be done in the pre-hospital environment? So in Reboa, you'll remember, they basically place a balloon in the aorta, and it's the equivalent of cross-clamping an aorta, except done internally without needing to open up a person to do it. It's not that complicated to do. You gain access to the common femoral artery, you float a wire, you place the sheath, you place a balloon, inflate the balloon, and secure everything for transport. This could be done under ultrasound guidance, and there's ultrasound technology that potentially could be used in the field. So it's certainly something that could potentially be used in the future to take care of devastating injury. The data behind it is reasonable. There's still more to come. But in this particular study, they were looking at using Reboa versus resuscitative thoracotomy, and the survival rate was much better in patients that got Reboa. Unfortunately, there's not a lot of evidence just yet, and in particular, there's no evidence that show that hemorrhage-related mortality is improved. So that was overall mortality, that last slide. And you would think that something more invasive, doing a resuscitative thoracotomy, could have its own morbidity and mortality associated with it. So Reboa could be something that's better suited to pre-hospital or remote settings, which again falls right into our wheelhouse. If you can't get immediate access to definitive therapy, maybe it would work. And in fact, it's been used, at least it's been published once. It may have been used more than once, but it's been published once. This is a paper from Resuscitation from this year. It was a helicopter EMS system in England that took care of a patient, had a 15-meter fall resulting in significant abdominal injury. They were unable to control shock-type symptoms at the scene. They had a 30-minute transport from the scene and did not feel the patient would make it to definitive care. So using ultrasound at the scene and Reboa with a physician-staffed air ambulance. They were able to place Reboa. The patient was in the hospital for 50 some odd days and ended up getting a complete recovery. So at least in this case, a really good outcome from this new technology. So where have we been? We know that bleeding kills people. When standard methods or Boy Scout methods don't work so well, there's decent evidence out there that tourniquets probably do work well. Hemostatic dressings, I still think are waiting to be totally proven, but I think they're commonly used in the pre-hospital environment now, and in fact my programs are using them. There are some new-ish things out there that are being studied. I don't know if this IT clamp will end up being just a gadget or gizmo, or will end up being something useful. TXA is a hot topic, and there are a lot of people who are really sold on the idea. Pelvic binders, again, my helicopters are carrying pelvic binders. My ambulances are not. I'm not sure they're proven just yet in the pre-hospital environment, but there's other cool stuff coming. And with that, I'll take any questions.
I guess I don't have a question. I do have one comment. We still have mask trousers in our protocol. I think we had a joint protocol with other regions. I think we accommodated some far north New York agencies who still wanted to carry it. But I think it's going to go off the new protocol soon. But there are some far-flung places still carrying mask trousers. And I couldn't believe there's really nothing for pelvic binders showing that work. We've been doing them for so long.
We do a lot of that. You know, think of backboards. How long have we been using backboards before we finally realized we were hurting people with them?
Yeah, I'm kind of surprised. I didn't realize put it that way. Here, I'm going to unmute everyone. I'll mute you all on again in a second if there's someone asking any questions. But does anyone have any questions for the presenter before we finish up? 3, 2. Oh. All right. Everyone's muted again. I want to thank Jeff for his presentation. That's excellent. I always want to hear about bleeding control and being the one to stop the bleeding, obviously. It's important. I do want to say for next month, we have David Tan from WashU in St. Louis doing a talk for tactical EMS. He's the upcoming president of NESP, I believe. We will have a change in schedule because of the Christmas holiday. We'll be doing it on the 20th at noon to accommodate the, Central Time. He has a conflict, but we'll do it at noon Eastern Time for next time's EMS, Medicine Live. And I would ask if anyone has any desire to present. We are looking for presenters for 2017 and could use some help with that. I see some program directors who are listening, so I'll say fellows are easy to volunteer, and our fellows have done a couple talks, done a good job. I'm sure yours can too. If you have any interest, just email me, and we will get you on the schedule. Otherwise, we'll post this on our Facebook page, YouTube channel, and everywhere else, and hope to see you next month.